mighty, great, compassionate, caring God, as a caregiving community, we are before you, seeking your help and guidance. God, the topic for today is preventing mental disorders in the communities around and promoting health. We pray that all of us here bless us with your thoughts and directions. We are grateful to your God, the way you have led the Medico Pastoral Association during the last 50 years, providing committed and diligent professional care to the mentally ill and their families. We are thankful to you. God, we are also grateful for holding us and sustaining us at our tough times. As we look around, we hear and see a lot of people suffer with the lack of basic necessities, particularly those senior citizens around us. This is where we need your help to understand the providing health and promoting life around us. Especially we remember those who suffer around without adequate necessities, basic necessities, feel rejection, abandonment, physical cruelty, and mental agony in their own homes. Many are victims of physical and mental illness, but no help for many of the thousands around. Many senior citizens also suffer psychological and spiritual dilemmas. Compassionate and caring God, give your community, all of us, passion, discernment, and commitment to hear the cries of these men and women around us. Guide us today as we listen to the speaker, Dr. Mathew Varghese, and help us to hear your wisdom. All these we ask in your matchless name. Amen.
Thank you, Dr. George. May I now call upon Ms. Rohini Rajiv, who is the chairperson of the Academic, Public Service and Publication Committee, and also a member of Managing Committee, to welcome the gathering. Over to you, ma'am.
Thank you so much, Jayanthi. It gives me great pleasure to welcome all of you to this wonderful lecture, the 10th Golden Jubilee lecture of the Medico Pastoral Association to commemorate 50 years of service to the society, service to people with mental issues. I welcome, first of all our volunteers who are here, everyone who signed in on a Saturday afternoon. It gives me great pleasure to see all of you present here. We have 43 participants already today. May I extend a special welcome to our guest speaker and our senior managing committee member, Dr. Mathew Varghese. Welcome, sir. Thank you so much for agreeing to do this 10th lecture for us. I welcome Dr. Joseph George, the president of the Medico Pastoral Association, Dr. Ajit Bide, our vice president, Dr. Srinivasa Murthy. May I extend a special welcome to you, sir, one of the most renowned senior psychiatrists. I also welcome specifically our staff members of MPA who have taken great interest in participating, especially today in the guest lecture. They've taken more than one role today, and I'm really, really happy to say that both in MC as well as in the vote of thanks. I welcome all the family members of our residents who have wanted to participate and listen into this lecture today. I wanted to also welcome Mr. Ganeshan, who has always been the sponsor for our guest lectures. The Zoom links are provided by his company, and everyone else that I missed out. I'm really happy to see all of you, because it's only when there are participants does the speaker also feel encouraged to talk about all the topics that we address, and every topic we've addressed so far has had special significance to mental health as well as to Medico Pastoral Association. I warmly welcome all of you once again, and I hand over the mic back to you, Jeffrey, to continue the program. Thank you so much.
Thank you, ma'am. Now I request Dr. Ajit Pide, Senior Psychiatrist and Honorable Vice President of MPA, to introduce the guest speaker, chair the session, and also to facilitate the discussion after the lecture. Dr. Pide has been associated with the MPA for more than 2 decades now, and he has served in different capacities, including President and Vice President of the association. Over to you, Doctor.
Thank you. Very minor correction. I've never been the president of the MPA, and I'm happy to serve under the
Next time.
presidents, Dr. Mohan Isaac and Dr. Joseph George. Welcome, everybody. Sorry, you are being welcomed over and over and over again. It befits the occasion. It is a signal honor for me to introduce my dear friend, who's had a longer association with MPA than even I have had, Professor Mathew Varghese. Mathew recently retired from NIMHANS as a senior professor. He had been the head of the department over there from 2013 to 16. The National Institute of Mental Health and Neurosciences, where he did his post-graduation. We have a commonality in that we did our undergraduate studies and our postgraduate studies at the same places. Mathew was just a couple of years junior to me, but he has shone in the academic field quite brilliantly. He was the senior professor of psychiatry at NIMHANS till 2021, and now he is an adjunct professor at his alma mater, St. John's Medical College, Bangalore, and also an adjunct professor at the Kasturba Medical College, Manipal. He's the head of the Department of Psychiatry. He was the head of the Department of Psychiatry, as I mentioned, between 2013 and 16 at NIMHANS. And he was the one who initiated a specific specialist clinic at NIMHANS, and that became a unit and a department by itself. He was the head of geriatric psychiatry after having been head of psychiatry department between the years 2016 and 2021. In this time, he was also in charge of the Family Psychiatry Center at NIMHANS. He's rendered clinical services, training and research in adult, geriatric, and family and community psychiatry. Being deeply interested in all modalities of treatment, Mathew was the supervisor for individual, couple, and family therapy. He has developed the family intervention programs for schizophrenia and dementia at NIMHANS, work that continues even now. He was a chief participant in the World Mental Health Survey at the Indian arm in 2006 and the National Mental Health Survey 2016 and 2022. Long aging study of India in the years 2020 and 2022. He is on the executive board of various research groups and professional societies. He is the author, including being the first author in many of these, over 150 publications. The Dementia India Report of 2010 and Dementia in India in 2020. What his printed biodata does not say is that he's an exceptionally compassionate individual who will go out of his way to help people solve their problems, and very, very humble about it. Never has he ever boasted about all that he has done, including the biodata that I just presented to you. Mathew's expertise in geriatric psychiatry, of course, is well known, but he's chosen an unusual and very appealing, intriguing topic for today. That is the prevention of mental disorders in the elderly. And we look forward to this stimulating, interesting, challenging topic. Over to you, Mathew.
Thank you very much, Ajit, for that very long introduction. I've known Ajit for almost 50 years now. And I bring you also apologies from Dr. Mohan Isaac, who I was with about an hour ago at St. John's, where we were discussing some postgraduate curriculum stuff for the National Medical Council. I must say my association with Medico Pastoral Association is almost 35 years. Ever since I got married to my wife, whose grand uncle was a Commodore Chaco. It was him who introduced me to MPA, and then since then, I've been on the MPA committees and different aspects of MPA in different capacities. So I must really thank the managing committee for having chosen me to speak. I mean, I'm the 10th speaker, and we hope to have many more speakers before we, finish with the 50 years. The reason I've chosen to talk about prevention in geriatric or elder mental health is because I believe that it's necessary to talk about this aspect in a large public health perspective, because it's very important to educate people about what can be done as far as mental disorders is concerned. And I'll tell you why that's so important. Because old age population is going to be something that is very important in our country. For example, in the last census, 2011 census, that is the last one. We missed the one that's supposed to be in 21 because of the pandemic. We had almost 9% of the population of India who are in the age group over 60 years. And it's estimated, so from 104 million in just a few years, in about 3 years' time, we'll almost reach 200 million, as that's projected, of number of people who are over the age of 60. And the reason that that's so important is because in the next 30 years or so, if you see India here, you will see that we will reach almost anything from 15 to 20% of the Indian population, which will be in the age group 60 plus. The developed world will, of course, exceed that. But if you look here, you will see that India will have a sharp rise from, what's there, 10% now to the next 30 years or so. We'll have a sharp rise of going up to about 20%, while countries in the West will have a very slow, gradual upward trajectory, because the number of people who are young are much younger, are much less in those countries. So because we have many more people who are younger, the younger population, in about 30, 40, 50 years, they'll all get to be old, and we'll have large numbers. Now, the reason why this is important is because India and China already has together the world's largest population of older persons. It's important because all of us know that about a half of people who are over the age of 60 or 65 suffer from some chronic illness or the other. And the usual chronic illnesses are, diabetes mellitus, hypertension, high BP, arthritis, vision, and so on. And they will have 2 or 3 of these illnesses. And many times I will explain to you in the next few slides, plus a mental illness. And if you look at mental illnesses itself, in the population of people who are over the age of 60, you'll find there's anything from 10% to over 30%. If you look at populations in general hospitals and nursing homes, the numbers go up to about almost 30 to 40%. But if you look at general population, it might be as low as about 8%. And the commonest mental disorders and the problematic disorders are really depression and dementia. And that is what I'm going to cover today in today's talk. I'm going to talk about how there might be strategies to prevent depression, dementia, and also I'll cover a little bit about suicide. This is not moving forward. Okay. Right. Okay. So I mentioned that the disabling mental disorders, namely depression, is about 10 to 20% of the population. And so at any point of time, right now, there might be over 10 million people with this illness, depression. And the good part is that it's a remitting illness and it can be treated. 3 to 5% of the Indian population that means about 5.4 million persons now, would have dementia. And this is a chronic illness. Unfortunately, there is no cure, and they all go on a downhill course till they die. Suicide also is a big problem in the elderly. And there's about a 12 in 100,000 population of people, elderly people who commit suicide. Now, this is a talk for lay people, though I'm happy to see many of my professionals here, but I will try to make this as simple as possible so that lay people can understand. In the area of medicine, when we talk about preventing illnesses, there are three types of prevention. One is primary prevention, and that means that you're trying to reduce the number of new cases that happen every year. That means you don't want to, if you had X number of cases last year, you're trying to see that you remain at X or go down from X this year. So these strategies are basically health promotion strategies where you do a large scale public health education and intervention to promote health. Now, secondary prevention, that's the second type of prevention, is basically to halt or slow the progression of the disease. So these are people who've already got the illness. So for example, if somebody's got hypertension or diabetes, you want to pick them up very early so that there are no complications, and you want to treat them so that they remain well and they don't get other disorders. So this is secondary prevention. That means people have got the disease, you pick it up early, and you treat it so that you don't get complications. The third type of prevention is tertiary prevention, wherein the people have the disease, it's become chronic, but you're trying to reduce the way that it's affecting them. That means that you're trying to reduce their disability. You're trying to see that they can function well in society. They can manage their complications and sequelae. And so what is done here is the core treatment that most hospitals offer in terms of treatment, rehabilitation, preventing relapse. These are the things that are done usually when it comes to the tertiary prevention. So in this talk, I'm not going to cover secondary and tertiary prevention so much because this is a talk about preventing illness. And so I want, and it's a talk for the public. A talk on secondary and tertiary prevention would really be for the physicians or the mental health professionals. So since it's a talk for the public, I'm going to aim this talk as to what you should know in terms of trying to avoid getting illness among your own family members and other people who you know. In primary prevention itself, there are three kinds of prevention again, and this is going to be complicated, but I'll try to make it as simple as possible. One is universal
Excuse me,
prevention.
Dr. Varghese, I think slides are not moving. Can you please stop? It's on elderly health problems right now.
Are you saying prevention?
No, sir.
No. We are elderly health problem. We are on that slide.
Sorry.
So just need to double click,
hold on.
I think.
Hold on.
Yeah.
Hold on. Can you see that now?
Primary
Yes.
prevention. Okay. Depression in elderly.
See this?
Primary prevention, it says.
Yeah.
Bottom
that's
line
right.
is indicated prevention. Now your slide says depression in elderly.
Anything?
Going back to primary prevention, universal, selective, indicated.
Yeah. So I was saying that universal prevention is something that you do with the general population, a large population, so that you can actually prevent disease from happening at all. And this is something that I'll discuss. Selective prevention is where you target specific people who have a disorder so that you prevent complications. For example, if somebody has got diabetes mellitus, you want to do some preventive aspects so that they don't get kidney problems or eye problems as you go along. So this would be, if you're targeting people with diabetes, so that they don't get blindness or they don't get a kidney disease, that would be selective prevention. So you target people who are at high risk for getting a disorder, say an eye disorder or a kidney disorder. In indicated prevention, you are treating people who have a mild disease, so that people have early symptoms, so that things don't get more complex. So all this comes under the realm of primary prevention as per the Institute of Medicine protocol. Now, covering depression, first of all, depression is one that happens in old people over the age of 50 years for the first time. It's important because they respond poorly to treatment and they can become quite chronic. Also important because vascular conditions like diabetes, hypertension, endocrine conditions like having low thyroid or diabetes, neurodegenerative diseases like Alzheimer's or Parkinson's, they're all risk factors, and people with these diseases can actually have depression much more than the others. Also, depression can occur when faced with life stressors like, for example, bereavement of a spouse or loss of a job or retirement. Other chronic physical disorders, for example, in tuberculosis, AIDS, cancer, heart disease, and so on, the number of people who have depression is 4 times greater than what you'd find in people who never had any of these diseases. And you will find depression much more in places like outpatient services, the admission services, nursing homes, and old age homes. In old age homes, up to 40 to 50% of them can have depression at some point of time. So the reason to know these risk factors is so that you can try and prevent depression from occurring. So I mentioned the importance of depression is that it can be a major risk factor for suicide in the elderly. So people with depression are a much higher chance of attempting suicide than people who did not have depression. It amplifies physical symptoms, it increases mortality. So people who have depression don't get very interested in taking medication. They don't follow up on their treatment. If they're supposed to go to the doctor and have cardiac checkups, they don't do that. And depression can actually, when it coexists with medical illnesses, it can actually worsen the outcome of medical conditions. So adherence can go down, can impair daily functioning, and often requires a lot of personalized long-term care with the geriatrician or the psychiatrist. So I mentioned that the risk factors of depression are bereavement, any kind of disability, people have any kind of disability, people living in disabled situations, having prior episodes of depression. Women are more susceptible than men. And if you do an MRI or CT scan, people who have shrinkage of the brain, what is called as atrophy of the brain, are more susceptible to have depression. I mentioned sleep disturbance here because in older people who have sleep disturbance, and this is the common problem in older people who have sleep disturbance can actually be more predisposed to have a depressive illness. So one of the things you need to do in terms of prevention is to take care of the sleep problem. Other risk factors are deficiency of essential nutrients, for example, vitamin B12, vitamin D, having less fatty acids in your diet, other drugs which might affect make you get depression. For example, if you're taking some antihypertensives, you could get depression. I also already mentioned the psychosocial situation, and I already mentioned that in physical disorders with depression, disability can get to be a big problem. So how can you prevent depression in the old people in a universal prevention strategy? Now, there isn't really anything much you can do in a large scale way, but if you advise the usual lifestyle changes that you ask people to make in terms of exercising, if people have a good mood, they are satisfied, they're happy, they're not living in a crowded situation, they have good sleep, they are religious or spiritual, these are things that could protect against depression. And having easy access to treatment and care, having insurance and having medical reimbursement are also things that might help people. Other things that we can do to help in universal prevention is that if you train physicians and geriatricians to recognize depression, then they could pick it up early and treat it early. So some of the strategies that we use are to educate physicians to improve their psychiatric knowledge and to improve their attitudes to mental health. We teach them to use screening scales, and these screening scales are some things that all of us can sort of just get off the net and use it. There's about 4 or 5 questions you can ask yourself or ask about somebody who's older person in your house, and this is something that you can do to actually screen. So this actually brings us to the realm of selective prevention, which is basically tackling seeing that you are taking care of people who are at risk. So who are the people at risk? People who have a sleep problem, people who have medical illness, people who have some kind of disability. You need to screen these people earlier on so that you can pick up early symptoms of depression. In people who have had bereavement, for example, they've lost their spouse or they've become retired, it might be good for them to go for counseling or some kind of therapy to get them to know how to adjust with their new life that they're going to lead. And the prevention of what is called as major depressive disorders can occur with education, some therapy which is called as cognitive behavior therapy, improving your own stress resilience by doing aerobic exercises, going for a walk, doing meditation, doing yoga, and improving your social supports and networks and problem solving. So the reason why many more people got depression in the pandemic is because they couldn't do some of these things. They couldn't go out, do exercise, they couldn't relax, they couldn't have social supports and so on. Now, indicated prevention, as I mentioned, is to treat people where you pick up symptoms of depression early. I mentioned about sleep, and sleep pattern in the past year can predict relapse to major depression. So it's important to get treatment or do sleep hygiene so that your sleep can get normalized. If that does not happen, there's a chance that you might actually go on to have elderly depression. You can do therapy. The therapies for depression are what is called as cognitive behavior therapy or interpersonal therapy, which can be given by a trained psychologist or a trained counselor. In some situations, it's been seen that low testosterone or sometimes even low estrogen in men or women can actually be a kind of forerunner for subthreshold depression that can occur in later life. So replacing these hormones or giving omega-3 fatty acids may aid in antidepressant therapy, especially in people who have got early symptoms, and that this is something that you can do for indicated prevention. Antidepressants, medicines, and psychotherapy alone are acceptable treatments for mild depression. And when late life depression or elderly depression is initiated by a stress, usually you ask these people to go for counseling or therapy together with an antidepressant. But as I mentioned earlier on, about 40% of cases of elderly depression respond to therapy within 6 weeks. And if you wait another 6 weeks, another 25% might respond. But a good 30 to 40% may not respond to single drug therapy. And so it might need a more intensive treatment. So what you're trying to do with this indicated prevention is to see that more serious depression and more prolonged depression does not happen. So very simply, the psychosocial skills for primary prevention are, taking care of the risk factors, identifying high-risk group, and then doing, some of the things that I mentioned in a fashion very quickly, so that you can try and prevent either early symptoms or somebody going into a depressive illness. Secondly, I'm going to cover suicide. And I mentioned that suicide in India is about 12 per 100,000 population. It increases as age increases. It's more in males. More males complete suicide, more in people who are unmarried, more in people who are single or in difficult situations. It can be more in people who have got an alcohol or substance abuse. I just met a patient last week in the outpatient where he was having an alcohol problem for about 15 years. And when he was drinking, he was very impulsive and he would get very emotional. And on one such occasion 2 weeks ago, he, on impulse, he just took some insecticide and tried to kill himself. Fortunately, he was brought to the hospital and he was saved. So alcohol and substance abuse can be one of the things that can, cause suicide or suicidal attempts. Similarly, people who have a mental disorder like depression, as I mentioned, can cause suicide, or people with a medical comorbidity can become desperate and try to attempt or complete suicide. So it's important to train physicians to recognize that people in these situations could have depression, might have a suicidal risk, and of course, for the government to monitor access and reduce access to poisons, drugs, firearms, and other lethal methods of, which can kill yourself. So in suicide, selective preventions are basically, in nursing homes and medical inpatient units, you will see what is called as an indirect or a sub-intentional suicide, where older folks there who are admitted, they refuse to eat, or they might have self-injurious behavior because they're quite desperate and they're not really keen on living. And so by starving or injuring themselves, they try to sort of kill themselves. So this is something that people in nursing homes and old age facilities need to recognize. And you need to train the staff and physicians to look for suicidal risk by administering suicide risk questionnaires. All of you have heard of the gatekeeper model, where you can, and Sahai and MPA has just finished a gatekeeper training where you can get gatekeepers to actually, people can phone in and have telehelp services. That can be one method of trying to sort of prevent suicide. There's an increased role of the family, and you need to educate family members about that. People in these situations can actually be a risk for suicide. And as I mentioned earlier on, if you pick up depression early and treat depression early, that might prevent suicide. The last part of my talk, I'm going to cover brain aging and prevention of dementia. And it's quite appropriate this month because this month is the Alzheimer Awareness Month. The World Alzheimer Month was in September, but the Alzheimer Awareness Month for the American Alzheimer's is actually in November. So the last few years, in the last, say, 6 to 10 years or so, we've got some insights into what could possibly prevent dementia. As all of you know, some of you may not know, dementia is a disease of old age. It's a disease where people have difficulty with forgetfulness. They have difficulty doing daily tasks. They have memory loss. There are changes in their mood and behavior. And as you go up in age, every 5 years, the number of people with dementia increase. So if at 65, you have 3 or 5% of the population who have dementia, if you have many people who are in the 80s, you will find that almost 20-30% of them might have dementia. And if you reach people who are in their 90s, like many people now live into their 90s, and almost 40 to 50% of them might have some kind of dementing illness. The causes are many. Today, I'll go into some of the causes which you might try and prevent, but the costs of dementia are high, and it takes a huge cost on not just the economy of countries, but also on families and friends who are looking after these. Now, in the last many years, we know that there are a whole bunch of risk factors for dementia. And on the left side of the screen are things that you cannot modify. You cannot change the way you're aging. You cannot change your sex, the fact that you're a female. You cannot change the fact that somebody in your family might have dementia, because all these things are bigger risk factors than not having them. You cannot change your genes. Somebody with Down syndrome can be more predisposed to having, dementia. If you had many past depressive episodes, you might be at a higher risk for having dementia. And people who have had repeated head trauma, especially people who are boxers or who indulge in sports which might, injure their heads, they might be more susceptible to having dementia. For example, that Muhammad Ali had Parkinson's dementia, and that's because he was a boxer. But on the right side of the screen, you can see a whole bunch of things that are modifiable. These are things that we can modify as we go along in our lives. One is called vascular risk, which I'll speak about a little later. And there's included in vascular risk are things like having high blood pressure, having diabetes mellitus, having dyslipidemia or high cholesterol, having certain nutritional deficiencies, smoking, consuming too much of alcohol, or being obese and or sedentary. So the WHO way back in 2019 and what is called as a Lancet Commission report. This is a report that is commissioned by the Lancet in 2020. And some of the updates of the reports later on showed that you could prevent cognitive problems in the elderly, whether it's a mild cognitive problem or something more serious like dementia, by handling about 12 of these risk factors. So I've listed them here quite arbitrarily because they might be interconnected. There are about 6 lifestyle factors that you can intervene with and see that you can reduce the risk of dementia. So these are physical activity, nutrition, tobacco, alcohol, mental and social activity. And there are diseases that you can treat, which is basically high blood pressure, diabetes mellitus, controlling obesity, controlling high cholesterol, treating depression, hearing loss. And to this list of 12, in the last few years, you're also adding on a few more, which is sleep disturbances and problems with sleep, and also pollution and overcrowding. So air pollution is a factor that is something that you can intervene with. So getting on to looking at the risk factors and getting on to what we can do, going back to universal prevention, and that is trying to see that you can reduce the number of cases that occur every year. Dementia is an illness that actually starts insidiously when you're in your 30s or your 40s. It might present itself when you're 60 or 70, but the disease has slowly started affecting your brain way back when you're 30 or 40. So there are various things that you can do from the time you're in your 20s or 30s, right through your lifespan. Actually, people say now, starting from the time of pre-birth to adult years and on. So these are basically various nutritional, educational, and active lifestyle interventions. So these are basically physical, mental, and social lifestyle changes and sleep. Physical activity, it's been shown by research that physical activity, aerobic exercise, can actually reduce cognitive problems in people who are normal, and also reduce cognitive problems in the sense that people who have mild cognitive impairment may not go on to get a serious dementing illness at a rapid state. Now, a healthy balanced diet, what is called as Mediterranean diet, but basically it's a balanced diet. I'll talk about that a little later. It's a WHO-based balanced diet. Is something that can be used again for preventing dementia. As all of us know, stopping tobacco and reducing the consumption of alcohol to permissible limits is something which is very important for brain health. It's important for the rest of your bodily health also, but it's important for brain health. Having good social activity is something, having good mental, social, and physical activity is something that's very important for primary prevention. What is not indicated, and I see a lot of people who are older or young people doing, which doesn't help, is taking vitamin Bs, vitamin Es, or polyunsaturated fatty acids, or even various multi-complex supplementations. People talk about keto diet and Atkins diet and a whole bunch of things, drinking coconut oil and a whole bunch of things, which are really not something that have shown to help. Just a few words about exercise. What is required is something very simple. 20 to 30 minutes of exercise daily. Try to do it every day, interspersed with strength training. Now there are trials going on all over the world called the finger trials, where they're using intensive aerobic exercise to see whether you can prevent dementia. But what is really recommended and what is known to help is not this intensive exercise, which many of us cannot do. Simple walking, which can be brisk walking for about 30 minutes every day, is something that can help very much. It does a lot of things in terms of improving your autonomic function and your cardiac endurance. So it improves your blood pressure, it improves your muscle strength, it helps you from not falling, elders from not falling, it helps with balance, improves your lung functions, improves your ability to get in and breathe oxygen, and by and large, it improves your immunity. And that's one of the things that is recommended during COVID, isn't it? That you do exercise because it improves your immunity. And improving immunity might in some ways indirectly be related to some inflammation that might occur in your brain and so cause dementia. So exercise is useful for people who are obese, people who have high cholesterol. And there are studies to show now that yoga, certain asanas, certain meditations, and certain exercises can actually improve sleep and cognition. This is shown from some studies that we have preliminarily done at NIMADS. And this helped healthy elders, and we are trying to do this in people who have early cognitive impairment and see whether it helps. Diet, I mentioned Mediterranean, but basically it's a healthy diet which is recommended by the WHO, which is basically a diet with low glycemic index food. That means not too much of rice and foods which are processed. So high fiber diet, things like unpolished rice or millets and so on, because they've got low glycemic index. In your diet, there should not be more than 40% of these carbohydrates, which are essentially whole grains. About 30% of your diet should be proteins. So various pulses, beans for people who are vegetarians, and for people who are non-vegetarians, things like fish or poultry. Red meat is not really indicated as a protein, good protein. But you must also have fats. And it's now known that about 10 to 20% of your diet should also be fats. And these are good fats, so-called good fats, which are contained in nuts and oils, which contain PUFA. Also important are micronutrients. So these are basically essential vitamins and elements that you might get from fruits and vegetables. So basically, having a balanced diet, cutting down on your sugars, cutting down on your high carbohydrate diet is something that must be done in terms of diet. Now, coming on to selective prevention, and these are people who we are trying to pick up who are at risk factor for dementia. So I mentioned to you that cardiovascular risk factors are very important to prevent dementia. So modifying cardiovascular risk, that means treating people who have got a high blood pressure, diabetes, high cholesterol, obesity, people who are inactive, people who had depression earlier or are likely to have depression now. Hearing loss is very important because many people who are in their older age groups might have a hearing problem. Many of them are not allowed to wear a hearing aid. But if you have hearing loss going on for a long period of time, this can actually reduce your cognitive problems and cause dementia. Somebody else is speaking. So can you
please, everybody except the speaker and the MC, please mute yourselves.
The other thing is to treat endocrine problems and deficiency issues. For example, if you have a thyroid deficiency, if you have low testosterone or lower estrogen, or a low B12 or a low folate, you can be predisposed to having dementia. Once you have dementia, these things really don't help to prevent or prevent the progression of dementia. But you need to treat these things so that you don't get dementia. So one of the things that's been controversial is this whole issue of hormone replacement therapy in women who become menopausal much earlier, say people who have had their hysterectomies at the age of 40 or 45. Now, these are people who should possibly take estrogen because estrogen will actually might help in preventing dementia in later life. Now, these indicated preventions are in people who have got early symptoms. So these are people who have got what is called as mild cognitive impairment. They have not become demented in the sense that they have not become, the memory problem is not made them dysfunctional, but they still have memory problems. And what is known to help in the last few years with various trials that are done all over the world is showing that cognitive intervention. So people talk about doing Sudoku and being mentally active, but there are specific cognitive interventions which are tasks, or they can be paper pencil tasks, they can be computerized programs, or things on your smartphone, or people have heard of luminosity. Now, these tasks, these mental tasks, actually help in improving concentration. They improve your immediate and delayed recall. And these things, when you do it and train to do it for a long period of time, they might actually halt, or they might actually delay the progression of mild cognitive impairment into dementia. So this is something that's known to help. The other, there's a medicine that might help in people who've got mild cognitive impairment, and that is called ginkgo biloba. It's a Chinese sort of herb, which is an over-counter medication that you can actually get. But this is still a little controversial as to whether it really improves memory or not, or it prevents progression to dementia or not. So to summarize, if you have, and you need to basically modify these risk factors and intervene. So if you have vascular risk factors, so illnesses like diabetes, hypertension, stroke, obesity, high fat intake, you need to pick up these illnesses early, treat them, have a healthy diet. People who are inactive, they need to have good aerobic exercises. People who are smoking need to stop smoking. You need to prevent falls, prevent head trauma by using helmets and protective devices for people who are at risk. Treat depression, pick up depression and treat depression early, especially depression which occurs in adulthood. So, last few slides. Can we reduce the risk for dementia? And the Lancet report says that about 40% of people who might have dementia, you could reduce the prevalence of dementia by about 40% if we intervene with these risk factors. So there are trials going on all over the world with different kinds of programs which might reduce risk. So very simply, what is good for your heart is also good for your brain is the adage. So what is that? Looking after your heart health and your brain health means being physically active, following a healthy diet, challenging your brain, so being mentally, physically, and socially active, and having a good social life. So in summary, and this is for prevention of all disorders that I mentioned. So it's for depression, it's for suicide, it's for dementia. And this is something, sort of 2 slides with take-home messages, which any of you can use in your own circle. You need to modify risk factors for all disorders. So if you treat hypertension, diabetes, smoking, and a whole bunch of things, you could prevent many of these disorders. If you educate your family members, physicians, health workers, pick up depression and depressive symptoms and pick up cognitive symptoms early, pick them up early, you could treat them early and prevent serious disorder. And so, very large-scale public education and awareness programs like the ones we're doing now is something that really help. You know, if you want to prevent suicide, you need to reduce access to poisons and lethal objects and improve access to treatment, have universal health coverage, have insurance, and reduce barriers to treatment. That means make it easier for you to go and access healthcare wherever you are. Again, I can't emphasize how it's very important to pick up things like diabetes and hypertension very early and continue to treat them effectively throughout your lifespan. If you have depression, get it treated quickly. Various psychological therapies and counseling, like problem-solving therapies or cognitive behavior treatments, they help. And above all, a healthy, active lifestyle, exercise, sleep, diet, socialization, mental activity, spirituality. These are things that really, if you do it from the time you're in your adult years and on into your elder years, these are things that can really help you to get old in a healthy fashion. And this is the decade of healthy aging for the WHO. And I just want to put up this this slide, this infographic from the WHO. Every older person is different. Some have the level of functioning of 30-year-old. Some require full-time assistance for basic daily activities. But what influences health in old age is a multitude of factors. Basically, way you behave. I mentioned to you a whole bunch of lifestyle factors that you can use to age gracefully. You treat age-related changes and illnesses. Have proper housing, have good socialization, have social and health facilities. And if you do this, and if you change our attitudes about older people and aging, if you change the way you think, change the way you think about aging and older persons, if you create environments that are age-friendly, if you can get health systems to change and become age-friendly, and you can develop systems of care, then you can really talk about healthy aging and an environment that is good for older people. So healthy aging is being able to do the things we value for as long as possible, and year after year, and to stay years ahead. Thank you very much. I will stop sharing and I'm happy to take questions.
Dr. Bide, I think you're on mute.
Ajit, unmute.
Thank you, Dr. Mathew Varghese, for that exhaustive presentation. It really covered the topic of primary prevention quite widely. But I have two questions to you, which I did not see figuring over here. One of them figures in the chat box as well. Two important contributors to elderly ill mental health, which are to a considerable extent preventable. One is the epidemic of loneliness affecting the elders quite a lot. We see this empty nest syndrome also, and there are children abroad who are willing to send, some of them are willing to send monetary support, but no physical presence or hardly any worth mentioning. And that causes a lot of grief and aggravates loneliness. Even otherwise, loneliness accompanies elderly people, especially when they are widowed. The second thing that I felt needed to be touched on, which is so preventable, is elder abuse. And we now have laws against it. I don't know how fair those laws are, but these are two facets that I would want your expert opinion on.
Yeah, so I think I covered loneliness, though I didn't call it loneliness. I talked about social networks and improving your social contacts. And that's really very important. So if elders are living alone, as it occurred during the pandemic, one of the things that's very important, and this is something that is suggested all through the pandemic, is that you make social contact. It might be using the media, it might be using anything else. It might be in elder groups, it might be in elder forums. Social contact is so important, and social networks are so important. And it's really important in preventing depression, suicides, and dementia. So though I didn't call it loneliness, it's definitely something that's very important as far as elders are concerned. Now, elder abuse is a very important thing as far as care of elders are concerned. And there are laws, as Ajit said, and we need to be aware of it. But elder abuse per se, in none of the literature is it really a risk factor for depression. Now, it might be a risk factor for, it might be indirectly a risk factor, because if there's elder abuse, then there's likely to be marginalization and there's likely to be isolation and loneliness, because there's a lot of negative emotions that occur when there's elder abuse. So it's indirectly related, but none of the literature shows directly that elder abuse is directly related to depression or dementia, or maybe suicide, but really no literature on that.
I think one of the things I suggest you take up is this, because we see a lot of it in clinical practice. Elders who complain about not being treated properly by the younger people. And sometimes there's a valid reason why younger people don't pay enough attention to the elders. The bitterness has grown over years. So suddenly expecting that the young people will be accommodative and supportive may not always be justified. We'll move on to the questions here. There are two questions, one from Mr. Theodore Bhaskaran and another from Mr. George Varghese, both of which center on ways of keeping the mind engaged. Mr. Theodore Bhaskaran says, what about music, reading, watching films, engaging in theater? I'm surprised you haven't mentioned any of these. And George Varghese, very understandably with the current trends, mentions the role of pet care, farming, gardening, going back to a bucolic life to reduce the risk of mental illness and depression. Moreover, what about studies on mental illness among transgenders? What about poverty? We'll come to poverty later, but these other strategies that Theodore Bhaskaran and George Varghese have mentioned, would you like to say something?
Yeah, so I think all those things that I mentioned, I have not specifically gone into, but anything to keep mentally, physically, and socially active is useful. So if you have pets, or if you're watching movies, or if you're reading books, or having book clubs, or if you're doing all the things that you need to do to socialize, all very important. There are people who have specifically looked at just using some of these therapies alone, pet therapy alone, reminiscence alone, dance therapy alone, and seeing whether they can prevent the progression of, say, memory problems or depression and so on. But the evidence for that, I'm talking about evidence, hard evidence here. But generally, doing all those things is definitely important, and anything that you find pleasant and makes you happy is definitely something that you can do to prevent many of these mental disorders. So, I mean, each person can choose what they want. Some people might like yoga, some people might like laughter club, some people might like to go to the park and meet all the elders in the morning, go for a walk. Some people might like pets, some people might like to garden, some people might like to just just go around doing things in their house. So whatever you like, each man or woman to his or her poison. Nothing really for me to recommend, in the sense that I can't, for somebody who doesn't want to do yoga, I can't tell them please start doing yoga. I've tried, and many times they say no, we don't want to do yoga. So it's purely up to your
inclination.
Yeah.
Mathew, there was some literature about 3 decades ago about doing things like word puzzles and Sudoku and things like that, which may slow down the process of dementia. Is there any robust scientific evidence for that?
Yeah, I mentioned that in passing. So any task that improves your concentration and memory will help. So the simple task that actually neuropsychologists prescribe to do cognitive retaining is basically, grain sorting. So you take a mixture of dals, tur dal, masoor dal, green gram dal, and so on, and you tell the older person to sort it out into the isolated dals. That is what is called as grain sorting. So that is something that can improve your concentration and your memory. Or just what is called as letter or cancellation or color cancellation. So you take a newspaper and you tell the older person to cancel out all the A's or cancel out all the words which are, with and or something, So that improves your concentration, and it improves the way you might, focus on something. Because one of the things that happens when you get old is that you lose concentration. Your mind wanders. And if you didn't do something very specifically to get yourself back on track, it's something that, that's very useful. So people do puzzles, people do crosswords. There are a lot of old people who can't get on in the day unless they do their crossword in the morning in the newspaper, or somebody who has not done their Wordle game, or Wordle is now very popular, isn't it? Sudoku, I think, is becoming less popular, but Wordle is very popular. So all these things are useful. If you're doing it, please do.
Okay, a related question, slightly peripherally, though very important. Dr. Kalyan Chandram, who gave us a brilliant previous Golden Jubilee lecture, has asked, what percentage of people with MCI convert into dementia? And is there a role for CHEI drugs, I guess cognitive enhancers, in MCI?
So about 12 to 15% of people who have got MCI. So if there are 100 people who have found who got MCI this year, about 12 to 15% of them next year would have converted to dementia, to florid, full-blown dementia. Now, the only drug that is being trialed and found to be slightly useful in mild cognitive impairment is ginkgo biloba and cognitive retraining. These are two interventions that are found to be useful to retard the progression of MCI to dementia.
Right.
Cholinesterase inhibitors are not indicated. Vitamin E is not indicated. Fatty acids are not indicated. These things are absolutely not indicated in MCI because they cause more sort of problems than cure.
Okay. Lissy mentions what I had touched upon.
But I just want to sort of focus on the question that Dr. Sundar asked, and that is that in people who have got mild cognitive impairment, it is very, very important that they get evaluated every 6 months with a geriatrician or a mental health professional, because you want to know if that cognitive impairment is progressing in 6 months' time. If it's progressing, and if the person is tipping into dementia or early dementia, then you must quickly start the person on a cholinesterase inhibitor. So that's very important. Just because you have somebody said you have MCI today, don't be complacent and say for the next 1 year I'm not going to do anything. But please do exercise. Please take care of your diabetes and hypertension. Please eat a healthy diet. Please be physically, mentally, and socially active. Please do all those things. And every 6 months, go for an evaluation where the professionals will do a neuropsychological test, a battery of tests to see whether your memory problems have progressed or not. That's very important.
Yeah, Lissy has mentioned the same thing we touched upon earlier. I feel elderly suffering social isolation and loneliness are more prone to depression and dementia. Okay, we'll move on from there. John Philip says, how can the society help aged persons to get out of the issue of depression?
Well, if you have depression, if somebody has clinical depression, that requires treatment by a physician or a psychiatrist. It needs a prescription, or it needs, if it's mild depression, you can do with therapy, specific therapies which are called cognitive therapies. You can't will a person out of depression. If you have clinical depression, that means they have certain number of symptoms: sleep disturbance, appetite disturbance. They feel totally gloomy all the time. They are totally listless. They are crying. They're thinking of suicide. No, if you have any of these 3 or 4 symptoms, if you feel disinterested in doing all the things that you're doing, if you have 3 or more of these symptoms, and if they persist for more than 2 weeks, it's likely that you have depression. Many times, in this early part of depression, many people, they refuse to go, saying that, oh, I have to try and sort of manage and try to will it away. If it doesn't go away in 2-3 weeks, please go to a doctor for so that the doctor can.
Matthew, your answer is very relevant and pertinent in a clinical context. I think the question is sociological. What can society do?
No. So if you have anybody in your family who's got this problem, please take them to a doctor, or coax them to go to a doctor. I have, in my own personal life, I've had many situations where I've had relatives who are in their 70s or 80s, who just felt listless, disinterested, just sat and slept the whole day. They stopped doing all the things that they were doing. Now, the family members did not pick up that it's a depression. But when it was described to me, because I am a trained psychiatrist, I told them that it's possibly depression. And each one of them, I got them to sort of talk to the person, went and talked to them, got them to go for treatment, and these people improved. So I'm not talking about a society thing. I'm talking about what each of us can do in our own families or with people who we know, in our friend circle, in our social circle. What we can do in society is something that is a bigger question which needs to be handled in a public health perspective. And I spoke about that. What can possibly be done in terms of societal things is what I said: people at risk, people who have got a physical illness, people who have got many of these physical illnesses that I mentioned, they are all at risk for having depression. So we need to take care of screening and finding whether they have depression or not early enough. So we need to train family members, train physicians, train as many people as possible in recognizing symptoms of depression. So
In a
I
similar
don't know
sort-
whether that answers the sort of public health perspective. Maybe getting this word out in a national sort of forum that, these are things that could prevent depression.
In a similar way, still on the societal level, especially with regard to our country, Dr. Joseph George, while complimenting you for your presentation, says, getting professional medical care for senior citizens, getting continuing health insurance for the seniors above 70 becomes quite challenging. What is your take on that?
Yeah, so it's recommended that there should be, we are moving slowly towards universal health coverage. We are moving slowly towards getting insurance for people. There are many schemes in the government which are there for older people and people who are poor, where people can actually get insurance for many of the disorders. Fortunately, in our country, as per the new Mental Health Care Act, mental illness is covered for insurance. It is not, in many countries, it's not covered. But here, one of the things that we sort of, when we help to draft the policy and the act, we said that this should be covered and the government should look after it. So though it's difficult, we need to get people to access elder care. And that's very important. And that's something that we should all advocate for.
Given the fact that you right in the beginning projected what a huge section of the society it is, don't you think the government needs to do enough to cater to this segment of society, especially the underprivileged parts of our society?
Yeah, so I didn't cover that. There are laws in our country. In passing, I mentioned about insurance and legislation, but there are laws in our country. There's a law called the Maintenance of Elders Act, which is basically a law saying that everybody over the age of 60 needs to be looked after by their family, by society, by police, by legal authorities, by everybody. There's a law. So, and the law has been used in many parts of the country. There are rare cases where somebody, a father filed a case against his son or daughter saying that he was not being looked after. But as per the law, actually in every locality, the police is actually supposed to go from house to house and survey and see who are the elders in that locality and what can they do to help them. That is there by law. So we should be aware of that and tell the police in our locality that there's an elder person around that they need to help.
Our police are so largely, there are exceptions, pockets of exception, I would say, where police are helpful, but otherwise they are so illiterate in terms of mental health. We need to do something about that. Now, there's a question, a very pertinent question, I think, that is very practical. When a lady in the house is in early stages of dementia, can she be allowed to cook?
Yeah, so I would say it depends. If she's supervised, and this is the same question that is asked me about driving, which is even more complicated, and people can actually get into an accident. So with regard to driving, for example, in the US or in the UK, the moment you are diagnosed as having dementia, then your license is just taken away. Fortunately, in our country, there isn't that kind of clear law which says if you have got a diagnosis of dementia, you should not drive.
We should have that, right? Don't you agree we should have that?
I don't know. I don't think so, because many spouses come and tell me that if you say my husband cannot drive, I cannot come to the hospital because he drives much better than me, and if I just have to sit next to him, but he'll do all the driving. He might lose his way, but if I sit with him and tell him where to go. Same thing with cooking. If a person with mild dementia is able to make toast or coffee or tea, then why not? They can do it as long as they're being watched, as long as they're not going to leave the gas on and leave the milk on and cause a problem. So they need supervision. It's very important to watch them. It's very important also to see that skill is not taken away from them, because the important thing in dementia treatment is to get them to do the skills that they can do, is to maintain skills that they have.
All right. The next question, actually, this person has also complimented you on your presentation and says, how can one get, I think you touched upon this, how can one get elders to accept, this is from Deepa, she says, how can one get elders to accept the fact that they may be having depression, given that there is so much stigma about mental health already, and unwillingness to accept that yours might be a case of depression. I think we'll have to stop the questions, but I agree with Dr. Kalyani Sundaram says, driving should be a no-no. Anyway, we'll debate this till the cows come home. Yeah, so could you tell us about this? Unwillingness to acknowledge that there's a problem, lack of insight, or a stubborn defense that, no, it can't be me. I don't want to be dragged to treatment.
Yeah. So, see, depression is such an insidious illness. It's not like somebody having psychosis and running crazy. You know, when somebody runs crazy and they have absolutely no insight, they just get bundled up and get to treatment. But depression is so insidious that people with depression take more than 6 to 9 months to actually come to treatment. So it is really a big problem. And people with depression actually suffer. And they themselves, if you have depression, you think that, you know, okay, this is what is happening, but I somehow try to do something to get out of it, not knowing that it's an illness. You don't want to accept that your brain is not letting you work, letting you do the things that you enjoy doing. For whatever you do, you feel negative, you feel that you cannot do it. And that, again, is a vicious cycle and makes you more and more depressed. So the only thing to do with depression is to really, if you know somebody who's become withdrawn, who's become, you know, asocial, has changed in his or her personality compared to what it was earlier on, is morose, is only talking about negative things, then you should talk to them and say, keep talking to them and say, this could be depression, this is something clinical, it's not your willpower, it's not your fault, you didn't do anything wrong, don't feel guilty, you need to go to a doctor. You need to sort of speak to them again and again and again and try and get them to understand that it's a disease that needs to be treated.
Persistent general persuasion.
Absolutely.
And hopefully it works. Bhaskar has asked something in a similar vein, so I won't repeat that. Bhaskar has also talked about elders who are stubborn in their attitude to not seeing a doctor. Hema, also from MPA, asks, are insomnia, she also compliments you on your presentation, are insomnia and sleep disorders the same, and can they be treated?
Yeah, so sleep disorders is a whole bunch of, you know, different conditions together. You can have something as serious as, say, obstructive sleep apnea, where you can have, you know, obesity, and you can have, as you grow older, your mouth and throat muscles can get lax, and you might stop breathing because of obstruction. So that is a serious thing which can cause sleep problems. But you can have something simple of, say the common thing that occurs now is that people watching TV on into the night, or playing games online into the night, or, you know, checking your social media into the night, and your whole sleep-wake cycle getting altered. And all of us are victims to that. You know, I can't say that I'm not a victim to it. You know, once you sit and watch, especially during the lockdown, when, you know, everybody was inside and you're just hooked onto your devices, you know, many of us, you know, slept late, or, you know, slept in early, or, you know, whatever. So sleep is a big issue, but having good sleep hygiene is so important for health, general health and mental health. So I can't really, I guess it's easier said than done. That, you know, if you get busy doing something, then you don't want to sleep.
Right. And Mr. George Varghese had asked this earlier. I had also mentioned it, but perhaps you just slipped your mind. Would you please briefly comment on mental illnesses among transgenders? George, our focus today is on the elderly, so we'll focus on the elderly transgenders.
Yeah, so there is very little work on the elderly transgenders. There is a couple of, you know, opinion articles that have been written, but the simple fact is that we don't really know.
George, Professor Maurice Carstairs, one of his early works when he came to India was on the Hijras, and he did mention how stigmatized they are, but we'll have a separate session on transgenders, or that will be part of a session on gender orientation and mental illness at a later date. I think that more or less covers everything that came up here for presentation, and I think we've finished in the stipulated time. Thank you, Mathew, for a very wide-ranging presentation and for fielding the comments and questions that came up for a very interesting discussion. I thank Rohini for giving me the opportunity to chair this very informative and interesting session. Jeffrey, back to you.
Yeah, thank you, Dr. Peter, and thank you, Dr. Varghese, for that imperative lecture on the subject. Now, I'd like to call Ms. Mercy Josena, the residential nurse of MPA, to cast a vote of thanks. Over to you, Mercy.
Okay. Good evening. Honorable Chief Speaker, present excellencies, members, staff, and my well-wishers. I thank Medico Pastoral Association for giving me this great opportunity to express my gratitude on this special day. As we all know, our inaugural lecture series was started by Dr. Mohan Isaac, and now we have hosted the distinguished 10th lecture, and more than 50 participants joined us today. On this special occasion, I would like to extend my heartfelt thanks to our Chief Speaker, Senior Professor of Psychiatry, Adjunct Professor of St. John's Medical College, Bangalore, Dr. Mathew Varghese, for enlightening lectures on preventing mental disorders among elderly. Thank you, sir. I extend my senior thanks to our President, Dr. Joseph George, and our member, Ms. Rohini, for beginning this lecture series with prayer and welcome speech. Thank you, ma'am and sir. My sincere thanks to our working committees, managing committees, and standard committee members for their continuous support and encouragement. Thank you all. Our program MC and our counselor at Medico Pastoral Association, Mr. James Jeffrey, had really mastered this event. Thank you, sir. I extend my heartfelt thanks to our Vice President, Dr. Ajit Bide, for his introductory speech about our speaker and also for moderating question and answer sessions. Thank you, sir. I should not miss out our sponsors, Micro Labs, especially Mr. Ganeshan, for their continuous association with us and generosity. I thank you, sir. I thank all our residents and family members for being with us. Finally, I would like to remind our God Almighty, my parents and family members for blessing us with opportunities and resources. Thank you all.
Thank you, Mercy.
Mercy. And thank you all for joining us this evening for this wonderful program. And good evening and goodbye until we meet in the next lecture series. And thank everybody. And please visit and follow our YouTube page where the recording of this lecture series will be uploaded soon. So thank you everyone and have a good day.
Thank you for being here and have a good weekend.
Thank you, everyone. Thank you, Dr.
Matthew, bye for now.
Excellent talk. Thank you so much. Thank you, Lorna, Father George Varghese, Hema, Tilaga and Bhaskaran, and Rohini.
Thank you, Dr. Mathew Varghese.
And all of you who is on the platform today. Looking forward to see you next lecture.
I should mention the next lecture is going to be delivered by Dr. Joseph George.
Thank you.
Is that in December or January?
December.
December.
Thank you, Rohini. Thanks, everybody. And
Thank you,
good
everybody.
evening. Have a good night.
Have a good evening, everyone, and happy weekend.